Hello, my name is Jordan Stamps, and I'm here today with Aaron McDaniel. We are student-registered nurse anesthetists at Franciscan Missionaries of Our Lady University in Baton Rouge. We are here today to present the dissemination of our DNP project in accordance with the graduation requirements for our Doctor of Nursing Practice Nurse Anesthesia program. The title of our project is The Impact of Non-Opioid Anesthesia on Postoperative Outcomes versus Opioids After Gastrointestinal Surgery. Medications play a large role in determining patient outcomes. During surgery, opioids are commonly given for analgesia and the physiologic responses that accompany the stress of surgery. Opioids, though, are frequently associated with unwanted side effects such as nausea, vomiting, ileus, and respiratory depression. Each of these preventable negative effects can lead to increased healthcare requirements and a longer course of stay at the hospital, specifically regarding patients undergoing gastrointestinal or GI procedures. Roughly 70 million people in the United States receive GI surgery annually. This high occurrence has prompted increased attention to multimodal pain management and enhanced recovery after surgery, or ERAS, protocols. Current evidence-based data shows that using multimodal analgesics will lead to improved outcomes by limiting narcotic usage in the perioperative period and therefore limiting opioid-related adverse effects. Various evidence-based research was evaluated, and the Ross-Worm and Larrabee model of evidence-based practice was selected as a framework to promote a focused approach to developing the systematic review. This model was chosen because it integrates both qualitative and quantitative data, which is relevant to this particular systematic review because pain is measured by both of these means. Key concepts of the Ross-Worm and Larrabee model include literature synthesis, research utilization, and change theory. The purpose of this framework is to transform research into a change in clinical practice. Historically, this framework has previously been used in acute care to recommend that patients with chronic obstructive pulmonary disease, or COPD, practice pursed-lipped breathing regularly in order to improve dyspnea. Steps of this model include assess a need for change, link interventions and outcomes, synthesize the best evidence, implement change, and evaluate the change. Problem statement and objective. Opioids are traditionally the first-line treatment for perioperative analgesia. Side effects from opioids hinder patient recovery, particularly in GI surgery patients. The objective of this systematic review is to determine if non-opioid analgesia provides improved patient recovery over opioid analgesia after GI surgery, as evidenced by decreased opioid consumption and improved postoperative recovery. The population of interest included adults receiving GI surgery with an ASA class 1 through 3. Patients above an ASA class 3 were excluded, as well as patients with a history of alcohol or drug abuse, in an effort to keep baseline demographics similar among included patients. Further exclusion criteria were specific to each article. The intervention of interest was non-opioid medications. Several medications were reviewed during the research, but the focus was on acetaminophen, lidocaine, dexmedetomidine, and parecoxib due to their practicality of their implementation into clinical practice. Opioid analgesia was the comparison of choice. Examples of opioids seen in the research included fentanyl and remifentanil. Several outcomes were examined throughout the research, but the focus for the systematic review included overall patient recovery and postoperative narcotic consumption. Other factors that influenced these outcomes included pain scores and length of stay. Types of studies included recent peer-reviewed articles in the English language. Studies not specifically pertaining to the above population intervention comparisons or outcomes of interest were excluded. Search strategy. The search included articles published from January of 2005 to September of 2020. Databases included CINAHL, ScienceDirect, ProQuest, Ovid, PubMed, and Medline. Search terms included gastrointestinal surgery, abdominal surgery, multimodal analgesia, regional anesthesia, nerve blocks, opioids, narcotics, pain medicine, recovery, length of stay, and pain scores. Advanced search modes were used and included apply related words, also search within full text of the articles, apply equivalent subjects, and or to combine search terms. Literature selection. 201 titles and abstracts of the articles were initially screened by both nurse anesthesia students. After excluding articles deemed irrelevant to the research question, 13 articles remained and were analyzed using the Joanna Briggs Institute Critical Appraisal Checklist. Both members of the dyad discussed the analysis and subsequently discarded 4 additional articles, leaving 9 articles to include. All surgeries were elective and all participants were at least 18 years old.
Six randomized controlled trials, a meta-analysis, a prospective cohort study, and a retrospective cohort study were included in the systematic review. The articles included research from the United States, Egypt, China, Brazil, Thailand, and the United Kingdom. The types of surgeries included were colorectal, both open and laparoscopic approaches, laparoscopic Roux-en-Y gastric bypass, laparoscopic sleeve gastrectomy, and laparoscopic cholecystectomy. Non-opioid interventions such as lidocaine, dexmedetomidine, and acetaminophen were the most commonly studied medications compared against opioids. COX-2 inhibitors were also included in these non-opioid medications. One study examined patient postoperative outcomes before and after the implementation of a multimodal analgesia protocol. Non-opioid interventions such as lidocaine, dexmedetomidine, and acetaminophen were most commonly studied. The authors studied outcomes such as pain scores, nausea, vomiting, and postoperative opioid consumption, as well as length of stay. Opioid analgesics are associated with a higher incidence of adverse effects than compared to multimodal analgesia after gastrointestinal surgery. Multimodal analgesics promote improved postoperative recovery and decreased narcotic consumption after GI surgery. Dosing was not definitive, but each of the different non-opioid analgesics did show at least one benefit in the area of postoperative recovery. Limitations of this systematic review included a lack of standardization for medication administration across the studies. This was a common limitation regarding multiple medications such as dexmedetomidine and lidocaine infusions. Strengths of the systematic review included well-designed studies and proven benefits of non-opioid medications across various healthcare settings and procedures. Challenges included removing the subjective nature of pain assessment, despite the availability of objective methods of measurements of pain. Recommendations include implementing multimodal analgesia is superior to opioid analgesia in improving overall patient recovery and decreasing the incidence of postoperative narcotic consumption. Data was significant in all but 2 studies, but even that research did still show some benefit in at least one aspect of patient recovery. Implications for practice include that non-opioid analgesia medications were shown to improve postoperative patient recovery and decrease narcotic consumption after surgery. This is important as it does prove significance for incorporation into practice. This systematic review did not show superiority of one particular non-opioid pharmaceutical agent over another. When implementing these into individual practice, dosing needs to be patient-specific, as well as selection of each medication needs to be based on individual patient characteristics. Implications for research. More research is warranted regarding timing of dosing of opioid-sparing techniques to make a more standardized administration regimen. Further research of double-blinded randomized control trials would help eliminate some of the bias-funded research. However, implementation of these double-blinded RCTs prove to be costly and take a large amount of time. Larger sample sizes in future research would also help strengthen the findings of the studies conducted. Attached to the next 3 slides are a list of references included in this systematic review. Thank you for your time for watching this presentation.